Appreciate being able to talk with all of you today. I have one disclosure which will not affect my content today. So what I'm going to try to do over the next half hour or so is to think about the female model. I know a lot about boys. I'm the mother of 2 boys, but my clinical practice is about 95% girls. And a lot of times we try to honor requests in our clinic when we can. The girls often want to see a female provider. The young men often want to see a male provider, and we provide that when we can. So I guess it's appropriate what are the topic that we were each assigned today. We have also built at Cincinnati Children's, where I was, in the Boston Children's, a center for PoI, and we've seen quite a few patients with APS. APS1 is most common, as we're going to talk about, but I treat a lot of girls with ovarian insufficiency. So we're going to talk about options for treatment, and then there are unique issues with the young versus the older adolescent. So what is female hypogonadism? So that's a big term there. So it's a condition that causes decreased function of the gonads. Dr. Chan just beautifully talked about the testes, so the ovaries in a female patient, and decreased production of hormones that play a role in pubertal development and development of the secondary sexual characteristics. A patient can be born with a condition such as APS1, or it can develop later in time. And what's interesting, using APS1 as an example, some patients go on to develop an ovaries, autoimmune attack of the ovaries, and some do not. I also care for, just so you know the range of my practice, patients with other metabolic errors such as galactosemia. I see patients who have had chemotherapy, radiation. So I see ovarian injury in a number of different settings. And the 2 broad categories of ovarian insufficiency are hypogonadotropic, due to a problem in the hypothalamus pituitary, as Dr. Chan just reviewed, or hypergonadotropic, which is where there's a problem with the end organ, such as the ovary. And as an endocrinologist, I always have to show negative feedback. This is, again, see if I can get there it is, the arrow. The hypothalamus here, in a pulsatile way, should be making GnRH, gonadotropin-releasing hormone, to signal the pituitary, the master gland, to signal the ovaries. And the ovaries in an adolescent girl should be making estrogen. When they make estrogen, there is negative feedback. I lost my arrow again, to slow down the secretion of LH and FSH. And the ovaries also make a protein called inhibin, which decreases the secretion of FSH. Otherwise, the ovaries would be overwhelmed by all of these signals. What happens in a patient with primary ovarian insufficiency is the ovaries are not able to make estrogen, and they're not working when LH and FSH are trying to signal. So clinically, what Dr. Chan and I see, Dr. Weiner, when we order labs, is that LH and FSH are very high. So they're being secreted by the pituitary, but it's the ovary is not seeing it. It's not functioning properly, and it can get higher and higher. And often the degree of elevation of the LH and FSH gives us a feel for how long this has been going on, the ovarian injury. So I agreed with what Dr. Chan said. We do take care of the icing on the cake, which is the best part. We occasionally have endocrine emergencies, but I would submit to you that delayed puberty can be an emergency for that adolescent. The adolescent boy or the adolescent girl can come to us very, very distressed. They do want it fixed overnight. And I think adolescents are constantly asking, am I normal? And they're comparing themselves with peers in the locker room, with their sister, with their brother, etc. So what we're trying to do is help them to catch up. So to develop the secondary sexual characteristics. In an adolescent girl, the first sign of puberty is breast development, soon thereafter followed by pubic hair development. So, and patients sometimes present to me with no development. Sometimes they've started development and arrested, or they have completely gone through puberty, but they may not have had that first menstrual period. So there's a variety of presentations of PoI. Ultimately, we're going to be working with them to try to induce the menses, as I'm going to talk about. It's very important for me to continue to think over and over about how tall is this patient, and I'll check a bone age x-ray to see how zippered up their growth plates are, because anytime I give estrogen, that's going to lead to progressive zippering closure of those growth plates. I'm putting my hand up here because, interestingly, we know a lot about growth plates in the hand. It's really easy to, as I say to little kids, we're going to take a picture of your hand, and from that picture we can even predict what the final height is going to be. And adolescence is also a very important period for accrual of bone density. As Dr. Weiner said, I've been on a mission to try to raise awareness about bone health in children and adolescents. If a young person does not gain bone density during a critical window, if I don't start estrogen progesterone at a critical window, then they could end up with a lower bone density. And then last but not least, estrogen is important for the brain, the central nervous system of an adolescent, and for cardiovascular tissues. This is who are candidates for hormone replacement therapy. These are those two categories, hyper and hypergonadotropic hypogonadism, and PoI, again, would be the hyper with the high LH and FSH. And you can see that autoimmune oophorytis, as we would see in an APS, is right there. So just briefly, we've talked all day about APS, what's in a name. There are a lot of different ways that this condition is termed in the literature. Let's be on auto advance here. I also, as has already been said, but I'll just underscore the points, the triad, the classic triad is hypopara, adrenal insufficiency, and candidiasis. I am on auto advance, sorry about that. But what's very interesting and challenging about the APS, hard for parents to know what to expect, is the varying clinical presentations. We've talked about the AIR gene today and even some of the HLA predispositions. APS is distinguished from the unrelated but more common APS. So APS2 is more common, but PoI is much more common in patients with APS1. I thought this was important to, in a tertiary care center, we see a lot of patients with a lot of rare conditions, so there are other types of APSs, as I'm sure you know. With APS2, just briefly, again, PoI is less common. Less than 16% of adolescent girls and women go on to develop APS2. And at advanced for me there's also an APS3, which is PoI coexisting with autoimmune thyroiditis. A take-home point, in the presence of one autoimmune endocrine disorder, I think all of us who are endocrinologists in the room are trying to get practitioners to remember to be aware of the increased risk of these additional endocrinopathies. So, and when I see a patient with PoI, I always measure antibodies, and I do some screening tests, which I'll show you at the end, considering whether at that point in time is there another endocrinopathy, or can I catch wind of a predisposition? So how do I screen? So teens with spontaneous PoI, so a patient who comes to me with either delayed puberty or arrested puberty, they are at risk, as we know, and what we're the most concerned about from the Endocrine Emergencies talk are adrenal autoantibodies. So 3% of women with spontaneous PoI will be found to have asymptomatic autoimmune adrenal insufficiency. And it was interesting, I found one article suggesting that women with positive adrenal autoantibodies, even if their adrenal function is normal, they should be followed with an 8 a.m. cortisol. I think part of all of our routine testing is a ACTH, but even if an ACTH is normal, that morning cortisol, if it's even borderline normal, we would do a full ACTH stimulation test. And that's where we give a small dose of ACTH, we stress the adrenal and see how much cortisol can be produced. So this is to make sure everyone is awake. You saw it there for a minute when it auto-advanced. So there's 3 stages as we think about pubertal development in a girl and supplying HRT. So the first stage, we're trying to mimic what Mother Nature does, is that initiation of breast development. We begin around the age of 12. We used to wait longer, but we at least start thinking about it at 12. From my experience, many years in practice now, adolescent girls are starting to look at peers in the locker room, the ballet studio at that age. And most importantly, we know that's when the ovaries should be turning on, and it's critically important for breast development, for bone development. Important for breast development and for bone development. In an adolescent girl, there will be unopposed estrogen that's secreted. In other words, estrogen is secreted by the ovaries by itself, and eventually there'll be ovulation. When there's ovulation, the ovaries make progesterone, so we have to mimic that. So for 6 or 12 months, we'll give unopposed estrogen. Again, we're watching the height, we're watching the bone age, we're watching the growth velocity, we're really studying the growth charts. Eventually, we're going to titrate in some progesterone because that's what the body would have done by itself. And we do that towards the end of puberty, or we'll do it when there's spontaneous bleeding. So stage 2 is further breast development, induction of menses, and then stage 3 are our young adults, any adult providers in the room, just maintaining the age-appropriate hormonal concentrations. Here's a growth chart. We spend a lot of time with growth charts. We think we always ask about the mother and father's height. That gives us information about genetic potential and where that young person, where they should be headed in terms of their final height. When I'm thinking about whether to start estrogen, I'm talking to the adolescent one-on-one. Then we have a group discussion, the adolescent and her parents. Are they ready for puberty, and when? Parents often say, no, we're not ready for puberty, but the adolescent can get increasingly anxious about being different from peers. I have to think about other endocrinopathies, any other diagnoses that adolescent might have. An example that comes to mind, a patient who had Crohn's disease. Was their Crohn's in remission? It would be good to get something else stable before I start a new venture on with estrogen, because it's going to be a big step for that adolescent. And again, I'm thinking about the growth potential, their current height, their target height from the growth chart, from the bone age, the predicted height. As I told you, I can take the height that day and then predict where they may end up. And then I'm also asking about bone health. Have they ever fractured a bone? Is there a family history of osteoporosis? About 75 to 80% of our bone density is dictated by genetic factors, and we're not genotyping every patient we see in 2019. So again, she's in the office. Who's the patient? Is she a young adolescent? Is she fully grown? Does she have primary amenorrhea, meaning she's never ever had a period? Or does she have secondary amenorrhea? Did she have that first period and then her period stopped? Does she have delayed puberty, or did she have delayed puberty? Did she start late, or did she start late and then it arrested? Did she start on time and then it arrested? Arrested would mean develop some breasts, develop some pubic hair, and then things seem to stop. In the older adolescents who I meet, and I take care of some college students, is she fully developed, completely developed in terms of breast would be Tanner stage 5, if you've heard of our pubertal staging, or not. Again, is she premenarchal, hasn't started periods, or postmenarchal? If she had periods, how long did her cycles last? Were they monthly or were they every 3 months? And how long did they last? Was it 1 day or was it the typical 5 or 6 days? Did she have pain with periods? Because that gives me information as to whether she was ovulating. Is she sexually active? Is she seeking contraception? I have to think about that when I think about what I'm going to prescribe. And then I'm asking about, has she ever been on estrogen, progesterone before, and did she have any side effects? Did she have breakthrough bleeding or spotting or both? And in the family history, is there a history of blood clots? Anything that makes me worried about giving estrogen, because estrogen can slightly thicken the blood and change the clotting factors. Okay, she's in the office now. Often these patients come and they're tired, and this fatigue in an adolescent is a tricky one, because I feel like 95% of the adolescents I see are tired, but if they're tireder than they used to be, or asking about sleep, are you a good sleeper? What time do you go to? You really have to get concrete. The adolescent, do you sleep well? Yeah. I sleep well. Well, are you tired? Yeah, I'm tired. So what time do you go to bed? What time do you get up? Do you sleep through the night? Well, I wake up sometimes. Would you wake up 1 time or 2 times? You're really getting a detailed history. If you get the history, well, I sleep 8 or 9 hours and I'm still tired, and sometimes I have to lie on the couch and take a nap when I get home. That's more the fatigue I see with estrogen deficiency. They just don't feel well, and sometimes they're not sleeping well. They'll wake up and they sometimes will feel hot at night. I found in the girls, unlike a perimenopausal woman with spontaneous menopause, they don't have as many hot flashes. They can, but they're not typically as dramatic as in an older woman, and they can have some mood changes. And that's also a hard one to evaluate in an adolescent, because the adolescents, their moods can change, but they're moodier than they used to be, is often what I hear from families. So on exam, I'm looking again, the height, the weight, is she symmetrical? So the body mass index, my starting blood pressure, because estrogen could up the blood pressure a little bit. I'm staging her for puberty. I'm looking for any other physical stigmata, which we're talking about today, any skin lesions. I'm looking at the nails, at the hair. I'm feeling the thyroid. Is it enlarged? Is there a goiter or not? Just to name a few. I talk with the adolescent about where their height is, and then I have the discussion, all that I just reviewed with you about. I'm going to give you estrogen for a few months, and then we're going to eventually add in some progesterone. I just briefly want to underscore that point of it's really important to lay the framework for an adolescent. I think with a boy or a girl, that I'm going to talk with you. I'm meeting you here with your parents today, but part of the visit is going to be just the two of us. There are a lot of questions, especially around puberty, that an adolescent is not going to want to ask in front of their parent. And so you often get the real story when mom or dad leave the room. And 99% of the time, families are fine with that private discussion as long as it's set up exactly what's going to happen. And the agreement is if I uncover anything where I'm worried about the adolescent safety or their medical well-being, then I'm going to have to break the confidentiality and tell the parent. But that rarely happens, thankfully. We have built at Boston Children's, and before, as I mentioned, a three-pronged center with pediatric endocrine gynecology and a social worker to be able to talk about the medical issues, to have a gynecologist available to talk about reproductive options, and then we have a social worker. And we really try to address the medical health as well as emotional health, because I think what's so hard about this diagnosis is often a parent is worried about their adolescent's fatigue, and they expect me to say that it's hypothyroidism, and maybe it is hypothyroidism, but they're also going into menopause, and they're 13 years old. And so it's shocking, as you know, for families. And so we feel like the three-pronged approach, we're able to meet all of the needs of our adolescents and their families. One quick example to share, one case I worried about what the adolescent was going to ask me in terms of reproductive options, and there was a big pause and there with her parents, and she just wanted to know if she could play soccer. And so that's where the adolescent was that day. She was 13, but the parents that day really wanted to talk to the reproductive endocrinologist, the gynecologist next door. So we also have the flexibility in our center where the parents could talk to one member of the team, and then they'll be there for the adolescent when she's ready. She was worried about soccer that day. I think it hadn't hit her yet what would be ahead and what we would need to do with estrogen, progesterone replacement, etc. This is estradiol. If we can, we start transdermal estrogen. Transdermal estrogen is a nice way to give a tiny dose to mimic Mother Nature. Some of the patches we can even cut into 6 or into quarters. If an adolescent has short stature, then I can really barely titrate up my dose. And then eventually, as I mentioned before, we'll add in progesterone, initially 5 days a month, and then go up to 10 or 12 days a month, and then menstrual periods will start at that point. Why do we encourage transdermal? Transdermal is a more physiological way to give estrogen. It can have a beneficial effect on lipids, on blood pressure, and inflammatory markers. There's no increased clotting risk because transdermally we bypass the liver. And there's also not a decrease in IGF-1, insulin-like growth factor 1, which is a signaling factor for the osteoblast. So oral estrogen can decrease very slightly bone formation, whereas transdermal, if anything, will increase it. I don't have stock in any of these preparations, but just so you know what's on the market, the Vivel dot, for example, is easier to cut and it's smaller, but all of these work really well, and some are once a week and some are twice a week. They can be quite expensive, so whatever your insurance will cover is absolutely fine. It's just understanding if it needs to be applied once or twice a week. Oral estrogen, again, because of that effect on IGF-1 and slightly decreasing bone formation, if an adolescent can tolerate it, the transdermal preparation would be better for bone as well. There are other options. I have some adolescents who absolutely don't want anything on their body. I've had an idea that maybe if we could make it look like a little tattoo, that maybe they would be excited about that, and I could convince some of them to do that, but some of them don't want anything to do with it, despite my trying. So the older options, the oral conjugated estrogens or 17-beta estradiol or ethinyl estradiol are on the market as well, and they work just fine. But it's just harder to titrate up very slowly like we can do with a transdermal preparation. For the older adolescents, I'm just going to fly through this. Older adolescents, college-age students, for hormone replacement therapy, when they're completely through their development, I can also use a vaginal ring. They are underutilized by adolescents. In one study, only 17% of teens had ever used it. It is a contraceptive method, but I'm using it here primarily for hormone replacement therapy. Etonogestrel is a metabolite of desogestrel. It's a progestin. As you can see, it's a soft, flexible ring that can be inserted with a tampon applicator, and has really been a nice model for the young woman. Can also provide contraception, as I mentioned. In general, I've found the older adolescents who are more comfortable with their bodies and inserting and taking something out are more enthusiastic about this method. I'm going to skip that in the interest of time. We've talked about bone health and making sure that the patient, Dr. Chan and I live in Boston, where it's dark and cloudy half the year at least. And so a lot of the patients we see are vitamin D deficient. So make sure your child is not vitamin D deficient, and making sure to ask again about osteoporosis and fractures. It's a critical period for bone health, and just like to remind you, like the growth curve, we see the same shape where there's a peak bone mass that's achieved around the age of 20. That's age on the x-axis and bone mass on the y. So we're doing all we can to get up to that full genetic potential for bone. So I'm going to end. Do I have time to just fly through a case? So PoI, again, is a form of pure hypogonadism, meaning that it's only estrogen deficient. Being only estrogen deficient is enough, but the reason I'm saying it that way, I see patients with eating disorders with something called hypothalamic amenorrhea, where estrogen's low, but cortisol is also high, IGF-1 is low. There are a number of hormonal alterations at the same time. So when I give back estrogen, it doesn't really help their bone density because there are too many other endocrinopathies that are off. So adolescents, again, such as this cartoon, have presented to me with pubertal arrest with PoI between the ages of 11 and about 17. Or they can have completely delayed puberty. And a girl, no sign of puberty at 13 would be delayed, so they've come to me that way. Or they can be fully developed and their periods have stopped. My adult colleagues see young women who present to infertility clinics, didn't know that they had PoI, and that's what it was. And so it's a really interesting model that's teaching us in patients with PoI with a variety of diagnoses how to give estrogen back. This is the order set that I alluded to earlier. There's some basic tests such as gonadotropins. I measure estradiol. I measure what's called anti-Mullerian hormone, AMH, which gives me a marker of ovarian reserve. I measure thyroid function, prolactin, a basic chemistry panel to make sure that hypopara is not brewing. I check their vitamin D status. I check their PTH. I look at the PTH to calcium and see if that's appropriate. And then I do check antibodies in all the patients who come to me with a high FSH. In terms of the imaging, I check a whole body and a spine bone density as a baseline in every patient I meet. They're often low at the beginning, but I'm happy to say that estrogen really works. A year later, there can be dramatic gains in bone density, and it's satisfying to be giving back the missing link. Their bones, their bodies need estrogen. Most importantly, these patients feel so much better when they get on estrogen. They're sleeping better, their energy level comes back, their quality of life is better because they're just able to function and feel better at school and in relationships with their friends. Here we go. So it's not, anytime I give this talk, it's not forgetting about an APS. So I guess we're all on a mission trying to raise awareness. And this is an example of a DEXA scan. When I get a bone age, it's often delayed. And this patient, she was chronologically 16 years old, but her bone age x-ray, she was only 13. So what I do in our DEXA unit, I correct the DEXA scans for the lower bone age, so I just report it both ways. A Z-score compares the bone density to age and gender match controls. It's a standard deviation score if there are any statisticians in the room, and -2 or less would be low for age. It's really hard, I know, to think in negative numbers, but -2 is our threshold, and so that's a low bone density for the whole body and the spine. This is the spine, by the way, as I'm sure you all know. And this is a whole body scan. Sometimes for fun, I'll show it to the adolescents. Some of them get a kick out of it, and some don't want to see it at all. But you can see even at the whole body, it was low. The whole body is mostly cortical bone. The spine is a different type of bone called trabecular bone that's metabolically active. So we look at both and we track each over time. There's the spine, -3.4. And this is what's classic. Again, the more metabolically, hormonally responsive spine is lower than the stronger cortical bone. So there's a lot that we don't know. What's really interesting right now, and I'll end with this slide, is in clinical practice we've made an educated guess as to how to give estrogen back and at what pace, and then when to start progesterone. I think we do a pretty good job because DEXA scans improve and the bone density measurements and patients feel better. But I feel like there are a lot of gaps in knowledge in this area, and I'd really like to better understand how much estrogen at what doses are needed for bone, for cognition, for brain development, and even thinking about cardiovascular risk, because we know that estrogen deficiency could lead to a higher risk, ultimately in adulthood, of strokes and heart attacks. So I hope this whirlwind through female hypogonadism was helpful. Pubertal induction really has to be individualized for each patient. I've shared with you kind of a general overview, but a lot of the decisions are made right there in the office, talking to the adolescent one-on-one and talking with their caregivers, thinking about what other comorbid conditions are there, thinking about bone health concerns. In general, as I mentioned, I start estrogen around the age of 12. And that has been a good starting point by expert consensus, but also in my practice just watching bone density and seeing the young people get happier as they get closer to where their peers are. I push transdermal with a ventral oral progestin. For the older adolescent, I didn't talk about it, you can also provide progestin with an IUD. And in that case, the IUD essentially will stop periods. And some of the older adolescents and young women really love that idea. They don't love having periods. Surprise, surprise. I monitor their height until they're fully grown, their blood pressure, their lipid profile, liver function, bone density, as I mentioned. Really pay attention to how they're doing medically, but also psychologically. And as I mentioned, there's a lot of important work yet to do in this area. Just like to thank my team. A lot of what I've talked about today, data has been out of Cincinnati Children's and then Boston Children's here in the corner, and then the funding that's made our work possible. Thank you.
Do you have time for a few?
Sure, yeah. No,
So
I think we're both on the 9 p.m. shuttle.
Okay,
so
we won't give you that long.
We're okay.
Yeah, so let's have some questions. Susan.
I have a question for Dr. Chan.
Yeah.
Boys. What if a boy is about 13, he's always had an advanced bone age by 2 years, hasn't started puberty, and is only 25% in growth on the growth curve for his age?
Yeah, that's. I think overall it raises a really good point that those age cutoffs are just, for the whole population. You really have to think about each person individually, and The people who tend to enter puberty later tend to have slightly slower rates of growth in childhood and tend to have delayed bone ages, not advanced bone ages. And if things don't start to make sense, that might be a reason to see someone sooner rather than wait until they're actually 13 or 14. So, that's a little unusual, right? Well, someone with an advanced bone age typically enters puberty on the earlier side rather than later side. So it may be worth investigating, without having to wait all the way until 14.
But what if you had investigated and really don't have cancer?
Yeah, and that's...
Would you start something like that oxandrolone, or are there concerns also about growth plates closing before puberty begins,
Yeah.
and then they don't get the advantage of the testosterone that kind of creates that spurt?
Yeah, these types of questions come up a lot in the pediatric endocrine clinic, the boy or girl with late puberty, and you don't know if they're going to eventually start puberty on their own or not, and what do you do? Do you treat or do you wait? And if you wait, how long do you wait? And and the child is tapping their toes, saying let's get going. People have tried various tests, but there's really not any great test that can predict. We're actually doing some research trying to come up with a better test, but it's still in the future. And I think it becomes a conversation with the family. How impatient is the child? How concerned is the family? And there's not a clear right or wrong answer. Treating with, say, 6 months of testosterone, there have been a lot of studies that shown that even if you do it at a fairly high doses much higher than what we actually use today, there doesn't seem to be a big risk of causing the growth plates to advance really quickly and fuse and stop growth and end up with short stature. That having been said, when we treat it, it's often a good idea to check the bone age really closely to make sure that doesn't happen, but it usually doesn't. So I generally think that treating with 6 months is unlikely to cause harm. Sometimes it can get things going, or at least sometimes it's just maybe even placebo effect, kind of Dumbo's magic feather. At least you're doing something and gives the child the confidence to, that something's happening, even if you're not really changing anything in the long run, that their body kicks in and they do fine from that point on.
I think it's what about that oxandrolone?
Yeah, so oxandrolone is...
I'm not worried about the child. The child's not worried. I'm worried about
Yeah.
final growth.
Yeah.
You know what I mean?
So oxandrolone is similar to testosterone, but the reason testosterone can advance the bone age and cause the growth plates to mature and eventually fuse is actually not a direct effect of testosterone. It's all mediated through estrogen. A little bit of the testosterone is converted to estrogen just normally in boys and men. And it's really the effect of the estrogen that causes the growth plates eventually to fuse. So oxandrolone is similar to testosterone, but it doesn't undergo that conversion to estrogen. So people have tried to use it as a way to kind of have some of the effects of testosterone without risking those effects of estrogen. I think it's reasonable. I don't know that there's any evidence that it's any better or worse than testosterone. And I typically don't use it, but some of my colleagues do. So it's not an unreasonable thing to think about. It's not a wacky idea. It's not going to be dangerous.
Yeah, and I don't tend to use it either, if that's helpful. I think probably more of us don't use it than use it, but it hasn't borne out to make a significant difference.
My feeling is that testosterone probably does just fine as well.
Robin, and then
I have a question for Dr. Gordon.
Yeah.
So if the incidence of PoI in girls is when these get one, it's about 40%.
Yeah.
And it's my understanding that people never start the period, or some girls start the period and then stop.
That's
so
right.
Assuming the latter case, is there a way to, or I guess what's happening in the world now with harvesting eggs and trying to preserve the ability to have?
So so the question is about harvesting eggs. So it's very easy to bank sperm, much more difficult to preserve eggs. Having said that, there's a lot of exciting research going on in that area. I think the advantage of a patient with APS, we know that their PoI is a potential some of the patients I see with PoI have idiopathic PoI, so it just kind of falls out of the sky. So I think APS is an exciting model to think about how to retrieve the oocytes early to preserve and save them. So I would really just say stay tuned and remain hopeful. I know of a lot of really promising experiments going on that are, I'm sure, going to advance the field.
So it's a reproductive endocrinologist that we should talk to?
A reproductive, that's right. So a gynecologist who has done a fellowship in reproductive endocrinology. It's confusing. So Dr. Chan and I, as pediatric endocrinologists, have an interest in reproductive endocrinology. It's the fertility specialists who think about this and are really the leaders in the research efforts. Yeah, sure.
Sorry, just to add a little bit more to that. So I actually would I think the field's matured enough that it is definitely worth consulting with a fertility specialist. There are kind of 3 levels of female fertility preservation. One is embryo freezing, which requires a sperm and a fertilized egg, and so that's often not an option for a teenager. More recently, freezing oocytes, the actual eggs before fertilization, has been labeled a legitimate or like ready for prime time treatment. It's been taken off that kind of experimental category. That having been said, it's tough. It's not always successful, but it's definitely worth having the conversation. And what people are really investigating now is actually doing surgery to freeze part of the ovary itself, possibly for future use. And that's something that is still considered experimental, but a lot of centers are looking into it. And it's a field that's changing very quickly, so what we say today may be very different even a few years from now.
Yeah, we're like a song and dance. As he said something, I think of something else. The oncology literature would be exciting literature for all of you to follow in this front, because I think they've done a lot with oocyte retrieval before chemotherapy, radiation, and leukemia and other malignancies, which I think is going to help patients with APS1.
So this is our last question.
Can I ask something really important for this?
Yeah.
Yes, you or anything to add, please.
There is a question that ideally all girls should have oocyte retrieval. The question is, being an expert in this, is there any research study ongoing in this country right now where patients can go and get referred for something like that? Because they can still go outside, but it costs about $30,000.
Yeah. Yeah, so the 2 centers that I know of, Cincinnati Children's, where I was for a few years, and Columbia in New York City, they are actively doing oocyte retrieval. Again, the problem I face with idiopathic PoI, by the time they present to me, the AMH is undetectable, so it would be hard to extract the oocytes at that point.
I think it would be useful to share that information.
Yes, absolutely. Happy to.
Several girls
Okay.
that are in the very early phases where
Yeah.
there's no avenue.
Perfect. Yeah, and colleagues there would be delighted to talk to families.
Okay, our last question.
I just wanted to ask, I've tried the epidermal patches in the past, and occasionally I'll have an overgrowth of staph, or I'll get like an infection or something, and I'll have to take myself off of it and go to the
Yeah.
pill.
Yeah.
And I know the patches are better for your bones, so is there
Yeah.
alternative sites that she can put it rather than
Yeah.
on her belly?
Yeah.
She put it on her back.
Yeah, so the good news, they can be put anywhere except for the face, and you wouldn't do that, right? Or the breast. Those are the only 2 places where you can't put it. So you can use it. You can put it anywhere else. And for my patients who have more skin sensitivity or have maybe a rash or what might be going on there, your skin might be breaking down a little bit and then the staph get in. It's just to really be rotated around, right side, left side. Absolutely. absolutely. And in fact, I would advise you to do that. And you're also less apt to have what's called a contact dermatitis, the itchy red skin around the patch. Yeah, I hope that's helpful. Yeah, sure. Oh, sure. The question was recurrent staph infections when the patch was used, the transdermal patch, necessitating needing oral estrogen for a while and then come back to the patch and it happens again. So really rotating and you have a lot of flexibility as to where you might put it. The other thing I try to think about from a practical standpoint is places where it's not going to get pulled off. So with the clothing you're wearing.
Thank you so much.
Yeah, sure.
Thank you, Dr. Weiner. Thank you, Dr. Chen and Dr. Gordon. That was a brilliant session. Thank you. So grateful. Todd will close us off today and we'll get to more food.
Okay. Thank you very much. I'd like to take a quick second. First off, I apologize, or we apologize, for the lack of Q&A time. I know you guys got a lot of questions. But please, take some cards tonight. If you think of something you thought about today or you want to ask questions, bring these back. I guarantee you the board will do whatever we can to get the question to the right person and get you the answers that you want. So we would have loved to have had a lot more Q&A in a couple of those sessions, especially this one as well. I'd like to thank all our outstanding speakers who provided a wealth of wonderful content today. I'd like to thank Jennifer for moderating today's session, which was a tough one because we were really cramming it in. Also, a little special recognition to Elise and the NIH team. The front cover of Science Translational Medicine, which was shared on her last slide, but she didn't comment because she's, so modest. But that was pretty amazing stuff there.